EUS-guided glue injection of aberrant vessel for recurrent hematemesis. No disclosures. The study was funded by Midas Medical Foundation. We present a case of a patient with recurrent upper GI bleeding secondary to an aberrant vessel arising from splenic vein thrombosis, which was managed with EUS-guided glue injection. His course before presenting to our hospital in the prior 6 months, he had 4 episodes of recurrent hematemesis, required over 10 units of PRBCs. He had 3 negative upper GI endoscopies with failure to control bleeding and 1 endoscopic ultrasound. CT scan showed narrowed splenic vein segment suggestive of thrombosis, dilated and tortuous vascular channels along the splenic hilum, and evidence of splenomegaly, but no evidence of any fundal varices. On upper GI endoscopy, the previously mentioned mucosal protuberance was identified along the lesser curvature near the proximal gastric body, and on retroflex view, this can be seen without any active bleeding. On radial EUS examination, the lesion was identified and appeared mostly mucosal. A linear hypoechoic structure was seen going towards the protuberance arising from a nearby vessel. On Doppler, this did not take any flow. Next, a power Doppler was performed and showed slow flow in this structure, measuring about 4 to 5 centimeters per second, suggestive of a vessel. And the vessel appeared to arise from the thrombosis and the splenic vein. And overall, it was felt to be an aberrant vessel arising from the splenic vein near the thrombosis, going towards the mucosal protuberance. We switched to a linear EUS scope, and on linear EUS examination, the vascular structure was identified and confirmed on Doppler examination. It measured about 1.2 millimeters in diameter. A 19 gauge FNA needle was then advanced across the gastric wall into this vessel, and needle tip positioned inside the vessel. Near normal saline followed by 2 cc of glue was injected successfully in the vessel. The needle was then removed, and a glue cast can be visualized in the entire course of the vessel. And this was confirmed on the radial echoendoscopic examination. Post-procedure, patient had no adverse events. 7 months following intervention, he has had no additional episodes of bleeding. Upper GI bleeding is a medical emergency. Occasionally, the cause of upper GI bleeding cannot be identified on upper GI endoscopy. EUS can serve as an important adjunct tool in patients where the source of bleeding is not found. This case additionally demonstrates the therapeutic capability of EUS for managing upper GI bleed by glue injection of an aberrant vessel. In conclusion, in patients with large volume bleeding, careful examination with EUS can help in identifying the source of bleeding. EUS can be invaluable in management of such patients where other modalities fail.